The third thing every nurse should know is is how to act in emergency situations. You don't have to know like the full ACLS protocol. A lot of units just have standardized as the BLS, and it's kind of all you need to know before the code team gets to you or rapid team. But it's still always good to know his protocols, just so you could help out, because the RR team might be, like I said, might be busy. Or there might not be enough rapid response nurses with you to do all these, you could say, these tasks that need to be done. So it's always, or the code team, for example, so it's always good to kind of know this kind of stuff. And if you're going to know, like one major one is, even though you're not required to know the ACLS protocol in your unit, it's still something that you should look into, because no matter what unit you're going to work on, you're going to have somebody code at least some point in your life, and you might just be doing CPR, but sometimes, like I said, the code team might be short, and you might need to help push meds. So it's also good to understand. Well, technically, you wouldn't be pushing meds if you're not ACL certified, but you'd still want to know like what they're doing and why, so you could be of some kind of a help, not just being like the just person standing in the room and clueless about kind of what to do. So I'm just gonna go over the ACLS protocol, just like real quick to touch upon. You don't gotta know like these specifics or anything like that.
And before you go into the ACLS protocol, something that every nurse should be thinking about or doing when it comes to critically assessing their patient in a emergent situation is just know your ABCs: airway, breathing, and circulation. You can start with those and see how they're doing to prevent things from going into a emergent situation where they might code. How is their airway? Are they having trouble breathing? Do you have to maybe boost them up in bed? Maybe you have to raise their bed a little bit higher. Maybe you have to supplement them with oxygen. How is their breathing? Are they agonally breathing? Maybe you have to bag them. Start thinking about things so before the code team comes and shit's being handled by the ICUnurse or the resident, whoever, you're already kind of troubleshooting things like low oxygen, slap on some oxygen, or you can, grab the bag mask and start preparing it if you already see this patient agonally breathing, something's going on. Or if they said, if it's a circulatory issue, they feel chest pain, maybe you already could start the process and get the 12 lead just so we're not delaying anything. So ABCs are important to think about.
Yeah, like I'm glad you brought it up, because like in theory you're doing like a quick assessment. Like you said, neuro, respiratory, cardiac, all that kind of stuff, like real quickly all at once. So then when a code team comes in, you could be like, hey, no pupils or whatever. There's a pulse, or there's a heart rate in the 160s, and there is a pulse. Or it could be heart rate in 160s. It's picking up on a monitor, but there's no pulse, because there's something like PA, pulse electrical activity, where it's still showing stuff, but there's really nothing going on.
And I get it. Like the beginning nurse is starting off, or you already might be experienced. Like sometimes you get into like that fuss where you're just not thinking about everything. You blank out. You can't even give a report to anybody because you just keep blanking out on what's going on with this patient. I totally was there, and I get it, and it gets easier, but just think about the basics, and hopefully the patient makes it through.
Yeah.
Most of the time it works out.
So like a quick ACLS, I'm not going to go through the whole thing. It's just like two different scenarios. So patient is basically in cardiac arrest. You want to for sure start CPR regardless. Then you also want to take into consideration the second thing, and this is like the major thing, is a shockable rhythm. So your shockable rhythms are going to be your VFib and VTAC, your pulse is VTAC, and then VTAC with a pulse, and then asystole and PEA are your non-shockable rhythms. So if they're in asystole and PEA, you're gonna keep doing CPR and push epi. That's all you're going to be doing. And if you're in a shockable rhythm, you're gonna be doing CPR, but you're gonna want to shock them at some point and also give epi, because that's what's going to help them the most, is that shock, not necessarily the CPR. The CPR is helping them, of course. You're getting some out of cardiac output, but you gotta shock them out of whatever rhythm they are. So that's like two major things to consider with the ACLS a protocol. You don't gotta memorize the whole thing if you're on the floor, but just remember those difference between your shockable rhythms and not shockable rhythms. And if they are shockable, you're shocking, CPR, and epi. And if you're not shocking, you're just giving CPR and epi, and hopefully the patient is gonna come back.
Yeah, because sometimes it takes like 3-4 minutes before the code team already gets there. If you're already starting CPR, you know that there's no pulse, you guys can go ahead and grab the freaking epi from the crash cart and push it. Right. I hope your hospital allows that to happen. And since we're talking about somebody coding, what I always do on all my shifts is just make sure your line is actually working.
Yeah.
So IV access is a big thing. Even if the flush isn't due, I don't care what unit I'm on. beginning of my shift, I have a bunch of flushes in my hand and I'm flushing every single IV. A lot of times I run into something that there's already a painful IV site. I got to pull it. It's leaking because it hasn't been flushed a couple of times. I don't know why this doesn't happen, but I like to get into the habit, and I think nurses should, to always make sure you have proper IV access, because you don't want to be flushing the IV during this emergent situation and your IV's blown to begin with a couple hours ago. Now you can't push critical care meds.
Yeah. Oh yeah, definitely. Like if you don't know what to do in an emergency situation, the best thing you could do is probably start an IV. Even if the patient has two and you're waiting for someone's doing CPR, don't stand there. Just maybe put a third one in, because like Matt said, they blow, and a lot of times, during an emergency situation, your body's going through like this giant stress, and sometimes your IVs just randomly blow when you flush it, or somebody's during a whole situation or a cardiac arrest, they just pop out of the vein or they pop through the vein and it's not being able to be used anymore. So IVs are super, super important, because you can't give them these critical meds if you don't have an IV. But I just want to clarify just real quick. The shockable rhythms are pulses, VTach, and VFib, and the non-shockable rhythms are asystole and PEA.